Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Jeff. How are you doing today?
Great. Thanks for having me.
Perfect. So it's been a hot minute since you were on last, so just in case somebody forgot, would you mind doing a real quick introduction of yourself?
Great. My name is Jeff Siegler. I'm an assistant professor of emergency medicine, and I'm an EMS physician at Washington University in St. Louis. And I get the fortunate position to also be the liaison from the National Association of EMS Physicians to the Special Operation Medical Association.
Perfect. And today, I'd like to go over a paper you had wrote, or at least the topic of the paper you wrote, about the use of ketamine and Statusepilepticus, which is a mouthful.
Yeah. So I was fortunate to hop on a project that had been started by a couple of other authors that were Nick Williams, Lindsay Morgan, and John Friedman. And the paper that they came and asked for my help was called Ketamine Efficacy for Management of Status Epilepticus, Considerations for Pre-Hospital Clinicians in the Air Medical Journal.
Yes. So if you wouldn't mind, because I got to be honest, I don't really know much about anything when it comes to status epilepticus other than what I Googled just before we started. So what is status epilepticus and how is it different from any other seizure?
Yeah, so seizures are the inappropriate electrical activity or discharge within the brain. They can be split across a couple different ways. You got your generalized, tonic-clonic, whole body seizures, and they can kind of go down into focal seizures where, just part of an arm or eye twitching or kind of lip smacking. And then you could even have the more rare absence seizures where nothing's happening and it's kind of like glazed over look. When a seizure occurs, it often terminates itself within a few minutes, and then if it keeps going, you get into what's called status epilepticus, which generally, for right now, we all agree lasts for 5 or more minutes of continuous seizure activity. Or you have a seizure, it stops. You're in that post-ictal, and ictal is the word for seizure, so post-seizure period or post-ictal. That period goes on for a certain number of minutes, and if you have another seizure while in that post-ictal phase and you haven't gotten your brain to start working right again, that would be considered status epilepticus. And then when that happens, kind of the alarm bells start going off because we're worried that this becomes like a fire that starts feeding itself, and the brain, once it starts into the status, can kind of spiral out of control. And status epilepticus can become like drug-resistant status epilepticus, and then they start adding these terms like refractory status epilepticus and super refractory status epilepticus, and it's largely just based on you keep failing, tier 1 medicines, tier 2, tier 3, tier 4, and they just keep working down, and to the point where you're in status for several hours or even days at times. And there's even a flavor of it called non-convulsive status epilepticus, where the brain's still firing out of control, but the body has stopped shaking, partially due to drugs that we give and partially due to the fact that the brain just is sitting there quivering, but not, theoretically quivering, but not actually sending stimuli out to the muscles.
Okay. And I'm sure you've seen a patient with status before?
Yeah, the both pediatric and adult world where I work and in and out of the hospital, we see seizures a lot for different reasons. Most, I would say the overwhelming majority of them are done before 5 minutes. So we often don't have to treat. It's rare to see a second seizure. It's rare to see, these prolonged seizures. But they still occur from time to time, so we have to be prepared to move down our treatment guidelines and moving from plan A to plan B, plan C kind of thing.
This is maybe a little bit off topic, but You mentioned, normally seizures will last a couple of minutes and you don't really have to treat. Why not, I guess, why don't you just jump into some kind of treatment if you can say, like, well, it should last only a couple minutes and then we won't have to do anything?
Yeah. It's hard. It's a difference of, if I come across you right now and you're seizing and I have there's no IV in place, I have no drugs drawn up, the time it takes to go start the IV or go to the locker, your med bag, the ambulance, wherever you're operating out of, and getting the medicine up, the seizure often stops. But if this was a situation where you're already in a facility, you already got your IV established, you got your benzodiazepine of choice sitting right next to you, you want to stop the seizure, and if you could, you stop it with a drug, and the patient will have less of a chance of going into that spiraling out of control, because you don't know if that seizure is going to be a 30-second seizure or a 30-hour seizure. So you would prefer to abort the seizure as soon as possible. You kind of play the odds game of knowing, okay, most of these stop on their own, but this could be the one that says, all right, green light, let's go, and the horse is out of the barn and you're not getting it back in.
Okay. Are seizures dangerous?
Yeah, they are, because your brain can actually start to die from the overexcitation and just continual, just like redlining, where your foot's on the gas and it's just going, and it can trigger these cellular pathways that can basically start killing brain cells, and eventually you'll stop breathing because you're seizing so much that you're not, if you've ever seen a patient who's having a full tonic-clonic seizure, that, the grand mal seizures, as other people call it, they're usually kind of hyperventilating, like dead space ventilating, where the air is just only kind of going in the throat and the large airways, but they're not really, ventilating. Their sats drop, their CO2 goes through the roof. Well, eventually you get a brain injury from hypoxia. You can get cardiac instability from acidosis. The CO2 can climb so high that you don't take a breath, so it just can start triggering all these things. So you want to ensure that the patient has an open airway, that they're ventilating on their own, or you're ventilating for them, you're providing supplemental oxygen, because each of these complications can injure the brain in a different way. And then it starts becoming cumulative, like you've got an anoxic brain injury and you've got cellular damage to the brain from, seizing for a certain number of minutes, and all that adds together, and bad things can happen.
Yeah. So kind of jumping into your paper and kind of the idea you're trying to push, you advocate ketamine for status epilepticus. Now, the current guidelines we're using tell us to use benzodiazepines, so either Versed, 5 milligrams IV or IO, 10 milligrams IM, or you can use diazepam, 5 milligrams IV, 10 milligrams IM. And I'm going to repeat that either 2 to 3 minutes with Versed, or I think it's 5 to 10 minutes with diazepam. That's your frontline stuff. And then it goes later on into like Keppra, phosphonatoline, which I've never seen, valproic acid, which I've never seen, and phenobarbital, which sounds pretty archaic and dangerous. So, all of those things, just what I've known about it, everything is built on relaxing the body, relaxing the brain, or just turning the brain off. Why would you think ketamine would work when everything, at least that I know about it, is excitatory? It's,
Yeah. So when I try to describe the actions of those two kind of concepts of the pathway that you just talked about with benzos, and then the second line agents, and then phenobarbital, and then you add in ketamine. When I describe why we do these things to my EMTs and paramedics, or to any other learner that I'm coming across, I describe the brain as kind of a gas and brake pedal in your car or truck. Benzos and the other drugs, they're meant to step on the brake harder, for lack of a better example. And then ketamine comes and it basically prevents you from stepping on the gas pedal. And so if you want to slow down, ideally you would step on the brake first, knowing that will slow the brain down, slow your car down. You also want to prevent you from accelerating, and that's what the ketamine does by preventing the excitatory pathway of the brain, which uses a chemical called glutamate. So, and this four-letter abbreviation called NMDA. Ketamine is a blocker of NMDA, and that NMDA receptor is the equivalent of the gas pedal in the brain. So if you want to stop the brain from going faster, step on the brakes and also prevent someone from stepping on the gas.
Okay. I didn't read this in the paper, but generally I would say medics such as myself on the aggressive side. So should I do both? Should I hit him with a benzodiazepine and a large slug of ketamine at the same time?
I'd say as of right now, we don't have the evidence to show that that's beneficial, and we have the prior experience of showing that may be detrimental, and I'll explain why. So one, we know that most seizures stop on their own, and most seizures stop with one or two doses of a frontline agent like a benzodiazepine. So now you're adding in an extra agent, which may or may not even be needed, and we have evidence that shows that combining sedatives, even though ketamine is touted to be protective of breathing, protecting your breathing ability, you add in a benzo, which we know is a respiratory depressant, and we add in the seizure activity, which is it's in and of itself a respiratory depressant. You increase the chance of the patient becoming respiratory distress or respiratory failure into respiratory, arrest, and that has problems in and of itself, which can cause brain injury, anoxia. And so, I don't know that we're there yet to say it is, it is better. Two is better than one. And so I think what we'll likely see in the future is, benzo, ketamine. As we've shown, benzos have clearly failed to stop the seizure. But right now, I'd say I would do, one before the next as opposed to both at the same time.
Okay, cool. How ideally, ideally it never happens to begin with, but let's say I have a guy with a traumatic brain injury. He starts having seizure activity. At least what I know, start doing some kind of benzodiazepine. Probably if I don't have access, I'm going to do IM, 10 milligrams. Hopefully that works. I imagine it's going to have some kind of effect at least. And if I need to, every 2 to 3 minutes, I'll do it again and again and again until either I run out or he stops altogether. Yeah. And now I have more problems, right? When should I start thinking about using ketamine instead?
So we don't know the timing of that yet. Everyone has a kind of a look that they're looking for when they're treating these patients of, I don't like how well they're protecting their own airway, so I'm going to step in and protect it for them. And up until that point, I'm going to be increasingly more aggressive with stopping the seizure. We know that seizures by themselves can cause you to stop breathing, and we know that some of the drugs like benzodiazepines can cause you to stop breathing. We're hoping that we can stop the seizure with our drugs before you stop breathing, but know that on the flip side of the coin, our drugs may cause you to stop breathing. So we're kind of doing this knowing some of these patients are going to stop breathing either from us or from the seizure activity. Right now, it seems like probably 3 doses of benzodiazepines is considered appropriate before you move on to the second agent. And it's one of those 3 drugs: levetiracetam, fosphenytoin, and valproic acid are the 3 kind of drugs that are in tier 2. And those, now the question is just, is ketamine equivalent to those and can be part of tier 2, or is it like tier 1.5? We just don't know that yet. And EMS and the pre-hospital providers, both civilian and military, are limited on what drugs they can carry. They don't carry the pharmacy, on their back or in their truck. So if we can use a drug that is going to be used for other reasons, that would be better than having a third drug that only gets used for the rare scenario of benzodiazepine refractory status epilepticus. Okay. So we're still working on the timing. We don't have the studies yet, but there's emerging data that says that ketamine is beneficial in seizures. It doesn't appear to be harmful, because that's the other side, is that, while it could be beneficial, it could be just as much harmful. Mm-hmm. So we want to know, does it even stop seizure activity with no appearance of harm, and figuring out, okay, is this now we, where in that first dose, second dose, third dose, are we doing it? Because we want the seizure to stop. So maybe we should be doing ketamine, like midazolam or Versed, and then throw ketamine as your second line, and then kind of go flip-flop, like alternating. We're working on that. We're trying to get people to come up with, randomized control trials to show this, this is a good strategy, or this strategy doesn't work, and we're on to the next strategy. Okay.
I've never actually tried to ventilate a patient who's seizing. I can't imagine that it's easy. Is it one of those things like, you do your benzodiazepine and you're continuing, but at some point you're saying, like, this guy, like, he's not ventilating. My SpO2s are falling. My end tidal is climbing, however you would be measuring that. I think he needs some kind of ventilatory management. Like, can you just bag through it? Like, do they comply enough that you can just bag? Or
as with all things in medicine, it depends.
Yes.
The patients who are initially seizing, I suspect, will have more respiratory muscle tone and may resist the bag valve mask breath going in, and so you may have to kind of just time it right and just kind of give them that constant, every so often when you feel like they're taking a breath, that you're kind of giving them that extra pressure. Similar to how you just talked, you had those 2 episodes on ventilator management, and that, so like a pressure support breath where they're triggering the breath and you're watching them and you're just kind of giving them that extra little squeeze with the BVM. But at some point, they're going to lose that tone. They're going to kind of soften up, and then you're going to be able to ventilate for them with more of a pressure control breath with the BVM or, some kind of mechanical ventilator. And then at some point, you just step in and
take over,
give them some drugs and put a piece of plastic in some hole and get some air in through that way.
Okay. At least what I found with the BVM, at least when I was trained to use a BVM, they said wash the chest. I found it not as easy as it looks, and a technique I found is if I put just a tiny bit of pressure on that BVM, I can feel the patient pull a breath. I've been able to time it a little bit better. What do you think about that?
Yeah, so what I suspect is that's the human version of a pressure-triggered breath, where with the ventilators you can trigger off of flow or off of pressure, and as the patient sucks in and dips the pressure dips down, your hand is that, like, you're waiting for that to give away, and so they're decreasing the pressure by a certain amount, and then you're following it up with that. So I would say that if we talked with some of the intensivists and respiratory therapists, they'd say, yeah, that's probably the equivalent of a ventilator waiting for a dip in pressure, and you're just there. You're certainly not over ventilating, or you're not like ramming air in and then having it go into the esophagus.
Yeah.
And so you're really just there waiting to feel that compliance in the bag change. And then you're just giving a nice supported breath.
Yeah. So just in my head, from what you've been describing, patient has seizure. I start doing benzodiazepines. Initially, hopefully, I would imagine maybe the first one is IM, trying to get either IV or IO access at that point, so I can now do IV or IO routes that way. do it 2-3 times, and then if you're not getting some kind of stoppage of the seizure, then go into ketamine. Now, are you talking sedation doses of ketamine, or?
So we think the ideal dose as of right now is 1 milligram per kilogram or more. So a sedation up to and including the dissociation, kind of that where you can, most people will do procedural sedation for something painful, like 1 milligram per kilogram. If they're going to do an airway management, they generally start at 2 milligrams. And it's just a matter of like, are you taking away that last little bit of, airway reflexes and muscle activity, and also how long is it going to last? But we don't think subdissociative ketamine and certainly that kind of danger zone ketamine are beneficial as of right now. More studies are needed to know, can we get by with the pain controlled subdissociative amounts, the 0.1, 0.2, 0.3 per kilo. So more to come hopefully in the future.
During the study, I imagine you guys either have done it or witnessed it or documented it in some way. I mean, have you seen good success with ketamine?
Yeah, I have anecdotal evidence. We're trying to figure out a way to get a case series published of a patient with a genetic syndrome, born with a certain kind of syndrome that predisposes that patient to what is basically benzodiazepine refractory Statusepilepticus. And we made an individualized care plan for this patient that after a certain amount of benzos were given, we would just give escalating doses of ketamine. And we saw really good, for a single patient over multiple episodes across a couple year period, we saw a really good effect to the point that the seizure activity stopped, and the family was like, well, we know that he's just going to stay at the hospital for a couple hours and then get sent home. Can we just have the patient stay here? And so we worked around that issue, but there is emerging comfortability. I mean, the paramedics across most of the United States are comfortable with ketamine because it's been out there for the last few years. And so they kind of know, okay, the 1,000-yard stare, the beating eyes, maybe some moans or squeaks. They know that the airway reflexes generally are going to be maintained. Maybe there'll be a little bit of saliva. So paramedics are comfortable with that 1 per kilo. So I think that's where we're going to stay for now until someone smarter than us comes up with an actual randomized control trial, like a dose finding trial.
Okay. Obviously, in your paper anyway, you're not able to like carte blanche give everybody permission to do this. But unfortunately, when the rubber meets the road and you're stuck and all you have is benzodiazepines in a shaking patient that you want to treat, is this something that is at least an option, knowing that you're going to have to answer to this to your medical director?
Yeah. Obviously, depending on where you practice will dictate, do you have a individualized or do you have the ability to even consider that, ketamine? Certain states won't even allow ketamine to even be used. So that's, you have to change state scope of practice or, military doctrine kind of to allow this to even be used. But in states that allow ketamine to be used for airway management, you can use it as an adjunct to initiate airway management and then decide how far down the airway management strategy you want to go. No different than, sedating a patient for who's in status asthmaticus, different situation, really bad asthma, that you want to put on a ventilator so that they ventilate and may or may not even need to place a breathing tube in them. So there is the ability to utilize the airway management strategy and use ketamine as, okay, I'm going to manage this patient's airway and see how they do from a seizure perspective. As with all things EMS, and you already talked about it with medical control, early use of medical control will allow you the ability to form a plan, even if you never get past step A or your primary of your PACE plan. what you can say is, okay, I've got a person who we either know is going to be a difficult seizure patient, or, they've been seizing for 5-6 minutes. We just got our first dose of benzos in. What are your thoughts on 1, 2, 3 more doses of benzodiazepines? And if that doesn't work, we try 1 milligram per kilogram of ketamine with the intent of monitoring their airway on, pulse ox, end-tidal CO2, supplemental oxygen, bag valve mask if needed. And if they are failing to maintain their airway, we will step in with basic maneuvers like jaw thrust, OPA, MPA, or go up the line of a supraglottic airway into endotracheal tube / front of neck access. So hopefully now emergency physicians are comfortable enough with ketamine to where they're like, okay, if they give a dose of ketamine, it doesn't automatically equal a ventilator. And so it allows both the paramedics and the or medics or corpsmen or whatever flavor of medicine you're titled, and the physicians and PAs and nurse practitioners who are overseeing them, allowing them to have this conversation, say, I'm comfortable with ketamine. I'm comfortable with ketamine. What do you think about ketamine if this patient is still seizing after 1 to 3 doses of benzodiazepines? Yeah. And hopefully everyone is on board with that.
Yeah, I think it's definitely smart to always, when you read something in a research article or wherever you get the information, before you end up pulling the trigger in a stressful situation, talk to your medical director, whomever they may be, and say, what do you think about this? I read this, I heard this, so at least you give some kind of forewarning. Like, I have one of my guys having this idea in his head, and he's just flat hatting around.
Yeah. It's always interesting to hear providers coming up to me like, I heard this on a podcast. What do you think about it? And you're like, okay, let's pull this idea apart a little bit more. And what is the evidence? If you read our paper, like, we wrote a review article of other papers that have been published, and so it's a lot of retrospective, observational. We don't have a version of what's called the Rampart trial, which was a well done study that looked at IM benzodiazepines versus IV benzodiazepines, where they compared IM Versed versus IV Ativan, and they had blinded, placebo, like one of the drugs was fake and one was real, and the patients got both, and they looked to see, which route was better, and they found that, and like we know now, initial IM benzodiazepines are better than attempting to get an IV on a seizing patient, and so that's what led us to going to IM midazolam and over IV Ativan or lorazepam. We need that kind of someone to repeat this with a ketamine version of Rampart, where we hit someone up front with, a blinded syringe of ketamine versus midazolam, and see maybe ketamine is better than benzodiazepine. We just don't know that part yet. But for now, have the conversation in the calm light of day, so that way everyone is, in theory, playing from the same sheet of music, and you're not like, where'd you get this crazy idea from? While I'm stressed and while you're stressed, and there's a patient in the middle that is, dropping their sats and not ventilating well, that's not the time to kind of, hash out these kinds of debates.
Right. This one time at band camp.
Yeah.
Right? Just a quick question about IM routes.
Uh-huh.
So this is kind of a debate back and forth. I've heard that lateral thigh is the best IM routes, just because it holds, from what I've heard, it holds its perfusion a lot longer. But yet I see people like stabbing essentially any other muscle that they can find. Is there any truth to that? The lateral thigh is better?
Taking the evidence from the anaphylaxis world with intramuscular epinephrine, the lateral thigh has been touted as the best, most vascular site for drug uptake. It also holds, a lot more volume than the deltoid. The problem with the glute is that depending on the patient body habitus, there can be a nice layer of fat between the skin and the muscle, and so your mileage may vary depending on the population you're treating. And so the thigh can hold the most and have what we think is the most rapid absorption of drug. And so we're kind of just borrowing from the epi world and pulling it over. That being said, if the person is hypotensive, the drug availability is decreased and takes much longer. You can hear a good conversation about the issues with that from other podcasts like MCRIT and emergency medicine cases with the AMAX4 protocol, and they talk about, if you're crashing from anaphylaxis, anaphylactic shock, your dose of epi can take 5 to 15 minutes to get into the system. So hypotension can occur at late stages of status epilepticus. And your dose of benzo or ketamine in the thigh may take a while. So this community is very comfortable placing intraosseous lines, and so I would say that early use of intraosseous lines is preferred over 3, 4, 5 IV sticks. If you have someone who you've deemed in status epilepticus, that is a critically ill patient until they're waking back up, and you never know if they're gonna go back down again. And so I'd much rather apologize for the mild discomfort of pulling an IO out later than having to deal with the complications of unmanaged or delayed onset management of status epilepticus.
Yeah, absolutely. When it comes to ketamine and status epilepticus, is there anything anything else you would like the listeners to know?
So we touched on in the paper the safety and efficacy of ketamine in the 0 to 3 month or the neonate period is very it's not very well defined. We think it's bad, so we're currently saying generally try to avoid the ketamine for those patients. We just don't have as much safety data, and so we could have problems. If ketamine is still somewhat frowned upon in the acutely psychotic patient, so if they start seizing, but it's that balance of, would you rather have them have their status epilepticus managed versus risk their psychosis getting worse? I would, as a medical director, as a as a paramedic and as a physician, I would say I would rather treat status epilepticus over dealing with psychosis, and so that's not really so much of a big worry. That, just like with any use of ketamine, it can drop your blood pressure. It's rare, but it's possible. So just be prepared to manage the hemodynamic effects of ketamine. And status epilepticus in and of itself can, for lack of a better term, kind of burn out your sympathetic system, and you can get these issues where you need to put patients on vasopressor infusions. Sometimes it's because of the seizure activity that's just overstimulating the body and kind of burning up all the catecholamines. Sometimes it's the drugs that you mentioned, like phenobarbital or propofol. Like those are drugs that can drop your blood pressure. So it's a mixed effect. Any sedative, whether it's ketamine or Versed or other, can slow or stop your breathing. So be prepared to just place patients in the recovery position while they are seizing, and then support their oxygenation and ventilation efforts. And we're still working towards getting that holy grail study of can we come out with ketamine auto injectors for status epilepticus? So more to come on that in the future.
Perfect. Hey, Jeff, I really appreciate you coming on.
Yeah, no problem. Thanks for having me. Love to come back and talk about anything else you need.
Perfect. I will.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.